Hello everyone, my name is Zahra Sabahi and I am the first year nuclear medicine advanced trainee. This is a research project that I conducted during my first few months of training at Liverpool Hospital, New South Wales. The title of my research is Diagnostic Performance of F18 PSMA-11 PET-CT compared with Gallium-68 PSMA-11 PET-CT in prostate cancer patients. Prostate cancer is the second most common cancer in men and among the main causes of cancer-related death. Prostate-specific membrane antigen, PSMA, is a transmembrane cell surface glycoprotein that is highly expressed at all tumor stages on the surface of prostate tumor cells, providing an excellent target for prostate cancer imaging and also therapy. The current most commonly used PSMA tracer in Australia is PSMA-11 bound to Gallium-68 via a linker HBED. Gallium-68 PSMA-11 PET-CT offers a few advantages. It's a highly sensitive molecular imaging modality for the restaging of prostate cancer patients with biochemical relapse and also for staging purposes. It is superior to conventional imaging according to previous studies. However, there are a few limitations. It has rapid urinary excretion and intense accumulation in the bladder, and hence some centers have the policy of routine administration of IV furosemide at the time of tracer injection to dilute urinary activity. This is an example of a Gallium-68 PSMA PET scan. You can see intense accumulation of urine in the bladder and also in the ureters, which can make interpretation of the primary site of disease and also nodal disease difficult. Next limitation is limited quantity obtained from the generator-produced Gallium-68, which is normally enough tracer for 3 to 4 patients per batch production. And as you might be aware, these generators are very expensive. On the other hand, F18 PSMA-11 PET-CT also offers a few advantages. It has hepatobiliary excretion rather than renal, and hence less accumulation of intensely active urine in the bladder, which can make the interpretation of primary site of tumor in the prostate difficult. It also has a longer half-life compared to gallium, 110 minutes versus 68 minutes. And hence, central production and satellite distribution is possible. It also offers the ability for delayed imaging to diagnose the equivocal lesions, which can be more intense on delayed imaging. Next advantage is shorter positron range and therefore better image resolution. Large-scale production is also possible in the cyclotron facility and central pharmacy, which can produce enough tracer for scanning of up to 20 patients per batch production. Here you can see an example of F18 PSMA-11 PET scan. You can see there is not much activity in the bladder. However, there is intense activity in the liver, showing hepatobiliary excretion. The aim of the current study was to assess the diagnostic performance of F18 PSMA-11 versus Gallium-68 PSMA-11 PET-CT in prostate cancer patients. With regards to methods, this was a prospective single-center observational and diagnostic imaging impact study conducted on patients referred to Department of Nuclear Medicine and PET, Liverpool Hospital, for PSMA PET-CT for either primary staging of newly diagnosed intermediate to high-risk prostate cancer or suspected biochemical relapse with prior treatment. Patient recruitment was performed between November 2019 and May 2021. Ethics approval was obtained from Human Research Ethics Committee. F18 PSMA I and gallium-68 PSMA-11 PET CT were performed within 3 weeks of each other, and both scans were acquired on a 5-ring digital PET CT, which was GE Discovery MI. Gallium-68 scan was acquired at 45 to 60 minutes after injection and 20 mg IV furosemide. F18 PSMA was acquired at 90 to 120 minutes without furosemide. Non-contrast low-dose CT scan was also performed for anatomical localization and attenuation correction. All scans were reviewed by the consensus readings of myself and 2 nuclear medicine physicians experienced in interpretation of PSMA PET studies. Number of active lesions in the primary site, regional lymph nodes, distant lymph nodes, skeleton, and viscera were recorded on both scans. Maximum standardized uptake values, SUV max, cutoff of 3 for lymph nodes and 2.5 for skeletal lesions were considered significant. SUV max of the bladder was also recorded for both traces. Management decisions were based on gallium-68 PSMA results. If there was discordant F18 PSMA findings, which might have influenced treatment decisions, then the imaging results and management decisions were reviewed at the genitourinary MDT meetings, which was held on a weekly basis, and decision on if biopsy confirmation needed was through those MDT meetings. Results: 54 patients were included in the study, 24 with newly diagnosed prostate cancer and 30 with suspected biochemical relapse. 1 patient with biochemical relapse was excluded from the study due to receiving treatment in between the 2 scans. This table shows the detection of abnormal foci in both scans. With regards to prostate and prostate bed, F18 was concordant to gallium-68 with detection of 44 foci in both scans. With regards to pelvic nodule, F18 detected 97 versus 101 on gallium-68. However, this was not statistically different with p-value of 0.34. With regards to distal nodule, again F18 was concordant to gallium-68 with detection of 45 foci. With regards to bone lesions, F18 detected 98 bone lesions with that had SUV max more than 2.5, and gallium-68 detected 74, and this was statistically significant. F18 also detected 2 liver lesions in the same patient, but those lesions were not added on gallium-68. Out of those 24 bone lesions, only 4 patients had lesions detected by F18 PSMA that were negative on gallium-68 PSMA, which could potentially have staging impact. However, they did not result in proven staging or change in management decision after MDT review and biopsy confirmation was not deemed necessary. This is an example of a pelvic node. Above image gallium-68 PSMA PET scan, the pelvic node shows SUV max of 4, The same note on F18, SUV max is 2.3, so it's not as obvious. However, it's still there. And this is an example of a bone lesion on gallium-68, which is SUV max 1.7, and on the same bone lesion on F18 gallium PSMA with SUV max 3.7. Based on bone lesion detection on gallium-68 PSMA, the site positivity and site negativity rates for F18 PSMA 1007 is shown in this table. The sensitivity means the fraction of patients with a bone lesion on gallium-68 that are correctly identified as having a bone lesion by F18 was 100%. The specificity means the fraction of patients without a bone lesion on gallium-68 correctly identified as not having a bone lesion by F18 was 88%. Positive predictive value of 82%, negative predictive value of 100%, and likelihood ratio of 8.5. Next part of the study was to assess the bladder activity in both scans. There was significantly more intense bladder activity even after furosemide administration with gallium-68 PSMA-11. This graph shows the percentage of patients with SUV max more than 8 was 40% in F18 group versus 68% in gallium-68 group. Only 2% had SUV max higher than 16 in F18 group versus 18% in gallium-68 group. This is an example of both scans, gallium-68 PSMA with intense bladder activity and versus F18 PSMA 1007 with not much activity in the bladder. Discussion. Our study is a prospective head-to-head comparison of the two traces. Very limited studies have compared the two traces head-to-head previously. Our results are in keeping with previous studies. Mingles and colleagues reported the F18 PSMA detection of bone lesion sensitivity 97%, specificity 89%, and positive predictive value 79%, which is very close to our findings. F18 has the advantage of potentially better delineation of the primary site of disease in the prostate, and this is due to significantly less bladder activity, which is a huge advantage. However, this needs to be further studied and correlated with MRI and histopath. With pending Medicare funding, F18 PSMA offers improved imaging capacity to help keep up with the demand. Conclusion: F18 PSMA 1007 PET-CT is largely concordant to gallium-68 PSMA-11 PET-CT with regards to primary tumor and regional or distal nodal detection, with additional advantages of less urinary activity and better image resolution. There is pitfall of potentially false and more benign bone uptake on F18 PSMA-11, but this has not resulted in upstaging or change in management in our study, as appropriate clinical context is taken into consideration in multidisciplinary setting. Further follow-up of patient outcome is required to support our findings. Thanks for your attention.